Hello, my name is Beth West, and welcome to my presentation on panic disorder. In this presentation, I will examine panic disorder through the lens of emotion and motivation, focusing on how dysregulated physiological systems and maladaptive coping responses contribute to its onset and maintenance. Drawing on current research and course concepts, I will discuss the biological and psychological underpinnings of panic disorder, including the brain structures, neurotransmitters, and hormonal responses involved. I will also explore evidence-based treatments such as cognitive behavioral therapy and pharmacological options while considering how cultural and social factors may influence intervention planning. I aim to demonstrate how a person-centered and culturally responsive approach to treatment can improve outcomes for diverse client populations. Panic disorder is an anxiety condition characterized by sudden recurrent panic attacks and ongoing worry about their recurrence. These episodes often involve intense physical symptoms such as chest pain, dizziness, shortness of breath, or a racing heart despite the absence of actual danger. At its core, panic disorder reflects significant dysregulation in the brain systems responsible for detecting threats, managing emotional responses, and regulating physiological arousal. The hypothalamic pituitary adrenal, or HPA axis, which regulates the stress response, often becomes overactive, contributing to heightened sensitivity to internal cues and prolonged anxiety. In this presentation, I will explore panic disorder through the lens of emotion and motivation, emphasizing how these processes contribute to both symptom development and treatment. We will take a biopsychosocial approach, imagining how the body, brain, environment, and learned behaviors all influence panic. By integrating physiological mechanisms such as carbon dioxide sensitivity and the brain's misfiring alarm system with motivational patterns like avoidance, we can gain a deeper understanding of the disorder and inform effective person-centered interventions. Panic disorder stems from dysfunction in the brain systems that regulate fear, stress, and emotional processing. Central to this dysfunction is the hypothalamic pituitary adrenal HPA axis, which activates the body's stress response and triggers the release of cortisol. When overactive, the HPA axis can heighten sensitivity to the perceived danger and prolong physical arousal. Researchers also implicate brain structures such as the amygdala and locus coeruleus. The amygdala signals threat, prompting an immediate response, while the locus coeruleus triggers noradrenergic activity that heightens alertness and bodily arousal. The periaqueductal gray, located in the midbrain, coordinates instinctive defensive behaviors, such as freezing or fleeing, and plays a key role in generating the physical sensations associated with panic. One striking feature of panic disorder is carbon dioxide sensitivity. Research by Sasaki et al. Shows that increased carbon dioxide levels can reliably induce panic in susceptible individuals, providing strong support for the suffocation false alarm theory. This theory suggests that the brain misinterprets harmless bodily signals as threats of suffocation, setting off an intense alarm response. When combined with dysfunctional regulation by the medial prefrontal cortex and the periaqueductal gray, this leads to misfiring fear circuits that generate panic symptoms such as breathlessness and dizziness, even without an external threat. The autonomic nervous system plays a central role in panic disorder by regulating physiological responses to perceived threats. The sympathetic nervous system, or SNS, which activates during stress, is responsible for the fight or flight response, raising heart rate, dilating pupils, and increasing respiration to prepare the body for action. In individuals with panic disorder, the SNS is hyperresponsive and triggers intense arousal in many instances, even when no danger is present. This overactivation results in bodily sensations that people often report during panic attacks, such as racing heart, shortness of breath, and trembling. In contrast, the parasympathetic nervous system, or PNS, is responsible for restoring calm after a threat is passed. When the PNS fails to activate, individuals struggle to return to a baseline state of relaxation. Taylor et al. Found that this imbalance between sympathetic activation and parasympathetic recovery creates what researchers refer to as autonomic rigidity. People with this imbalance remain in a heightened state of physiological arousal, which increases their vulnerability to recurrent panic attacks and makes them more sensitive to stress in daily life. Panic disorder involves several key neurotransmitters and hormones that influence emotional regulation and physical arousal. Serotonin plays a crucial role in modulating mood and mitigating overactivation in threat detection regions, such as the amygdala. Researchers have linked low serotonin levels to increased anxiety sensitivity and poor emotion regulation. Norepinephrine, released by the locus ceruleus, intensifies physical symptoms such as rapid heartbeat, sweating, and hypervigilance, amplifying the subjective experience of panic. While these imbalances explain why even minor stressors can trigger overwhelming fear responses in individuals with panic disorder. Another essential chemical is gamma-aminobutyric acid, or GABA, the brain's primary inhibitory neurotransmitter. GABA helps dampen excessive neuronal activity, enabling the brain to regulate fear and anxiety with greater efficiency. In people with panic disorder, reduced GABA activity leads to heightened nervous system arousal and difficulty calming down after a stress response. Elevated cortisol, the body's primary stress hormone, further disrupts this balance by reinforcing overactivation in the HPA axis and increasing emotional reactivity. Together, these neurochemical disruptions make the brain more reactive to both internal and external cues of danger, sustaining the cycle of panic. The fight, flight, or freeze response is an automatic survival mechanism designed to protect us from danger. In panic disorder, however, this system activates when no real threat is present. The sympathetic nervous system prepares the body for escape or confrontation with perceived danger by increasing heart rate, muscle tension, and breathing rate. For some individuals, the freeze response takes over, marked by physical immobility, a sense of disconnection, or an inability to speak. Braca notes that this freeze reaction is widespread in those with trauma histories, as the nervous system may default to a passive defense when fight or flight seems impossible. Rolas and Lopez et al. Emphasize that anticipatory anxiety can prime this defense system, rendering it hypersensitive to even mild internal cues, such as dizziness or shortness of breath. This hyperreactivity creates a feedback loop. The body detects a harmless signal, misinterprets it as danger, and launches a complete panic response. Over time, the brain learns to associate the sensations of fear with fear itself, reinforcing avoidance and reducing the person's sense of safety in everyday environments. Understanding this misfiring of survival instincts is key to helping clients reframe their experience and regain control. Panic disorder develops through a complex interaction of genetic, cognitive, and environmental factors. Family studies suggest a strong heritable component, with individuals more likely to experience panic if they have a biological parent or sibling with anxiety-related disorders. Environmental stressors, such as trauma, neglect, or chronic invalidation, can trigger or intensify symptoms, especially when they lead to long-term alterations in brain chemistry. These changes may occur through epigenetic mechanisms, which influence gene expression based on life experiences. Cognitive vulnerabilities also play a key role. One of the most important factors is anxiety sensitivity, which is the belief that bodily sensations such as a racing heart or dizziness pose a danger. This fear of fear fuels hypervigilance, making people more likely to detect and catastrophize minor changes in their bodies. When anxiety sensitivity combines with biological predispositions and stressful life events, the threshold for panic decreases to a lower level. Understanding how these risk factors accumulate helps clinicians personalize treatment and reduce blame, empowering clients to approach symptoms with curiosity rather than shame. Panic disorder often co-occurs with other psychological conditions, particularly major depressive disorder, otherwise known as MDD, generalized anxiety disorder, or GAD, and post-traumatic stress disorder, or PTSD. Lecuvier found that more than half of individuals with panic disorder also meet the criteria for another mental health diagnosis. These comorbidities can complicate treatment by increasing emotional distress, reducing treatment response, and prolonging the duration of illness. Segeli and Kara Mustafa-Lioglu emphasized that co-occurring anxiety conditions like GAD often lead to more persistent symptoms and a higher likelihood of relapse. Panic disorder is often confused with a physical health issue. Many clients seek help in emergency rooms because they fear they are having a heart attack or asthma episode, often due to symptoms such as chest pain, dizziness, or shortness of breath. Zaubler and Caton noted that these overlapping symptoms often lead to unnecessary medical evaluations and delays in psychological treatment. For clinicians, this means adopting a holistic view, assessing both psychological and physical symptoms to avoid misdiagnosis and create integrated care plans that meet the full range of clients' needs. Cognitive behavioral therapy, or CBT, is the most effective treatment for panic disorder, supported by extensive research. It includes several components: psychoeducation, cognitive restructuring, and interoceptive exposure. The latter involves inducing panic-like sensations such as dizziness or rapid heartbeat in a way that ensures client safety to help them build tolerance and reduce fear responses. Otto and Devaney emphasized that interoceptive exposure is one of the most powerful CBT tools because it teaches clients that bodily sensations can be uncomfortable without posing any danger. This approach challenges the core fear of panic, that it is unmanageable or harmful. Some clinicians worry that exposure techniques may overwhelm or re-traumatize clients, particularly those with complex trauma histories. However, Pompoli et al. Found that exposure, when well-paced and supported, yields strong outcomes. Other therapeutic modalities, such as psychodynamic therapy or mindfulness-based cognitive therapy, may also be effective, particularly when a client struggles with avoidance or emotional suppression. As de Abreu-Costa et al. Argue, the most important factor is not rigid adherence to a single approach, but instead tailoring evidence-based strategies to meet the client's emotional, cognitive, and cultural needs. Medication can be an effective tool in reducing the severity and frequency of panic attacks, primarily when used alongside psychotherapy. The medications most often prescribed are selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs. These drugs work by increasing the availability of key neurotransmitters, helping to regulate mood, reduce anticipatory anxiety, and stabilize the brain's stress circuits. These medications are generally safe and well tolerated, making them first-line pharmacological options in clinical guidelines for panic disorder. Clinicians also utilize benzodiazepines in some cases due to their fast-acting effects. While concerns about dependency and sedation exist, Sumarai et al. Argue that short-term use under supervision can be safe and effective, especially for clients experiencing acute distress. Older medications, such as tricyclic antidepressants and monoamine oxidase inhibitors, or MAOIs, treat patients effectively, but they could cause more side effects, so doctors reserve them for treatment-resistant cases. The healthcare provider should continuously individualize the decision to use medication based on the client's symptom profile, comorbidities, and personal preferences. Cultural background plays a decisive role in how individuals experience, interpret, and respond to panic symptoms. In some communities, individuals may express panic through culturally specific idioms of distress, such as ataque de nervios in Latinx populations. These expressions often involve intense emotional and physical symptoms, but people may understand them through spiritual, social, or interpersonal frameworks rather than psychiatric ones. Roy Byrne et al. Point out that clients from marginalized groups may not describe their symptoms using conventional Western psychological language, increasing the risk of misdiagnosis or missed opportunities for intervention. To offer adequate care, clinicians must tailor interventions to the client's cultural values, beliefs, and support systems. Hinton emphasized that religious practices, family involvement, and culturally meaningful metaphors can enhance client engagement and outcomes. Gonzalez takes this a step further, proposing that cultural adaptation should move beyond surface-level translation to embed community norms and coping strategies into the therapeutic structure. Whether through group support, storytelling, or spirituality, aligning treatment with a client's cultural identity improves trust and helps them feel seen and respected throughout the therapeutic process. Support systems play a critical role in recovery from panic disorder. Group-based interventions, such as cognitive behavioral group therapy, provide clients with a sense of shared experience and help reduce feelings of isolation. Galassi et al. Found that these programs help participants gain confidence in managing symptoms while normalizing their distress. Although some clinicians question whether group settings can meet individual needs, Soares et al. Demonstrated that group CBT, cognitive behavioral therapy, can be both practical and accessible, particularly for clients with limited resources or those seeking peer support in conjunction with professional care. Beyond therapy groups, broader support systems such as family, primary care providers, and lifestyle practices can significantly impact treatment outcomes. Research by Caton et al. Demonstrates that collaborative care models in which mental health professionals and medical providers work together to coordinate treatment increase engagement and satisfaction. Additionally, Lambert emphasized that healthy routines such as regular sleep, physical activity, and a balanced diet can help regulate emotional states and reinforce the gains made in therapy. When clinicians assess and incorporate these supportive elements into the treatment plan, they help clients build resilience and sustain long-term progress. Panic disorder is a multifaceted condition shaped by dysregulation in both emotional and physiological systems. From hyperactive stress circuits and neurotransmitter imbalances to learned patterns of avoidance and anticipatory anxiety, this disorder reflects the complex interaction between body and mind. Treatment must reflect that complexity. Cognitive behavioral therapy, pharmacological interventions, and mindfulness-based strategies each play a role, especially when therapists personalize them to fit the client's needs and preferences. Recognizing the impact of culture, environment, and motivation is equally important. Recovery is most effective when clients feel understood not only as individuals with symptoms, but as whole people with values, beliefs, and strengths. Hinton and Gonzalez remind us that integrating culturally responsive practices, motivational principles, and strong support systems yields outcomes that are both meaningful and lasting. Through this holistic lens, panic disorder becomes not something to manage, but something clients can overcome with support, insight, and courage. Thank you for taking the time to engage with this presentation on panic disorder. I hope the information shared has provided a deeper understanding of the emotional, physiological, and cultural factors that shape this condition, and the evidence-based strategies that can support healing. Please refer to the following slides for a full list of the scholarly sources drawn from and cited throughout this presentation. Bye.